Specialty Stories, session number 17. Whether you're a pre-med or a medical student, you've answered the calling to become a physician. Soon you'll have to start deciding what type of medicine you'll want to practice. This podcast will tell you the stories of specialists from every field to give you the information you need to make sure you make the most informed decision possible when it comes to choosing your specialty. Welcome to Specialty Stories. My name is Dr. Ryan Gray, and I am your host here today. Today I have an interesting episode for you, an interesting interview with a pain medicine specialist. Now, Dr. Fred Weiss is a radiologist by training for his residency and then did a fellowship in pain medicine. Now, what's interesting about this interview is that Dr. Weiss actually isn't practicing pain medicine right this very second. And we're going to get into why he's not doing that. And it's part of what he doesn't like about pain medicine. One of those questions that I ask in this podcast is, what do you like the most about your specialty, and what do you dislike, or what do you like the least about the specialty? And what Dr. Weiss talks about as liking the least is part of the reason why he's not practicing pain medicine right this very second, although he is intending to get back into it soon. So let's go ahead and jump right in and learn about pain medicine.
Sure. My name is Fred Weiss. I am currently an emergency trauma radiologist at Geisinger Health System in Danville, but previously I was a pain medicine physician in Florida.
And how long have you been practicing?
So I finished my last fellowship in 2014-15 year, and been practicing as an attending for about 2 years now.
You said your last fellowship. Have you been through more than one fellowship?
Yeah, I did 2 fellowships. So my first fellowship was a half and half fellowship in neuroradiology and musculoskeletal radiology.
Okay. And then the second in pain medicine?
In pain medicine at University of Pennsylvania.
Wow. Okay. We'll talk a lot about everything today. When did you know you wanted to be, I guess specifically a pain medicine doc?
That's a good question. So actually, I'm a physical therapist by background before going to medical school. And I always really enjoyed the musculoskeletal system and the neurologic system. And I found those the easiest for me to understand and digest and, put into practice, all throughout PT school and then in medical school. And then as I was going through my rotations, I had that affinity toward that. And I didn't really know. I tried neurology rotations and physical medicine rotations, and I enjoyed all the subspecialties that were affiliated with pain. Things in the periphery like orthopedics and neurosurgery, et cetera. But ultimately, I didn't see myself as a surgeon. I really liked interventional radiology type procedures that are performed by interventional pain docs. And then, it was a matter of choosing a base specialty for going into pain, which was really what specialty that I thought dealt with neuro and musculoskeletal procedures the most.
Okay.
So
what traits do you think lead to being a good pain medicine doc?
Oh, what traits? So lots and lots of patience, compassion. A lot of patients are, every patient is in pain to some extent, acute, chronic. You see mostly chronic as a pain doctor. I think right now, and it sounds kind of odd, right now the best trait to have is patience with the political system and the medical system that we're in right now, with all the complications going on with opioids. And, a lot of physicians feel like they have targets on their back, but I think more so than others, pain physicians feel that the most because they're prescribing opioids, and the country is going through a national opioid epidemic right now.
Interesting. Let's go ahead and talk about that for a second. You mentioned that you're doing diagnostic radiology now, but you are a pain medicine trained physician, and you were doing that. Do you think, you mentioned this, the opioid epidemic that we're in, do you think that there is a lot of misunderstanding about what pain medicine doctors do to have that target on your back?
Yeah, absolutely. So, there's going through the interviews for attending jobs, you see a lot of diversity in how people practice pain medicine. There are those who practice only interventional procedures, the image-guided procedures we talk about, injections, epidurals, facet injections, nerve blocks, spinal cord stimulators, etc. There are those on the opposite end of the spectrum who only prescribe pain medications. And when you only prescribe pain medications, there are really only like a few classes of medications that are prescribed. The largest class would being opioids. And then there's the people who are in between, who are kind of moderates, right? Moderate amount of injections, moderate amount of pain medications, and go from there. There's a lot of diversity, a lot of heterogeneity in the way people practice. And so it leads to a lot of doctor shopping and a lot of people who can abuse these medications, seek these medications. And there are those people who really need it, and there's people who don't. And you have to have a lot of ability to be able to screen that out and follow evidence. And it's difficult. It's a very difficult thing on a day-to-day basis, not even day-to-day, but patient-to-patient basis, to figure out who's a good candidate for certain medications and for certain procedures, and who will respond and who will not.
Outside of the interest in the interventional aspect, the procedures that you talked about, was there a draw to the specific patient population for pain medicine for you?
Yeah, I mean, it stemmed from my background in physical therapy. In the PT world, my specialty, so to speak, was manual therapy. I really enjoyed putting my hands on someone and making them feel better, whether it be gently mobilizing their spine, or mobilizing their knee, or doing massage therapy, things like that. I really enjoyed the manual therapy aspect of it. And so, as similar to osteopathic medicine, I took a lot of continuing education in that sort of topic, and really enjoyed it, and it kind of drew me toward that because I had good success in those sort of techniques. And I wanted to carry that over to the pain medicine field and how I practiced. And to some extent, I was actually fairly successful in getting patients off pain medications simply using manual therapy techniques and other modalities, complementary to other things. So,
you mentioned osteopathic medicine. Are you an osteopathic physician?
I'm not actually. I actually, when I applied to medical school, I applied to 9 osteopathic medical schools, and I got rejected from all of them. But somehow I was accepted to 5 allopathic medical schools, and I ended up going to GW. So go figure.
Interesting. Okay. Now you briefly mentioned the base specialty for pain medicine. Can you talk briefly about the different ways into pain medicine?
Sure. So when I was in medical school, there were only a few subspecialties, few specialties who could be eligible for pain medicine fellowship, and it was anesthesiology, of course, the largest take, physical medicine, neurology, and psychiatry. And I had done rotations in all of those, and I didn't really, I liked them, I didn't really love them. And when I did my rotation in radiology, I had met an interventional radiologist who did a good bit of pain management procedures, Anthony Venbrooks, at GW, and he was fantastic, and he had follow-up clinic with his patients, and it was really quite enjoyable, and patients did well. And so I said, well, I'm going to go into radiology and eventually interventional radiology, and follow from there, and do just the pain part of interventional radiology. But ultimately, when I went into radiology, I found that when I was doing my interventional rotations, the only part of interventional radiology I enjoyed was the pain procedures. And really, to be great at it, not just good at it, but be great at it, and practice comprehensive pain medicine, I wanted to do a fellowship in pain medicine. Along the way, I had met a mentor of mine, Wade Wong, who is a neuroradiologist and a neurointerventional radiologist, trained diagnostic radiologist at UC San Diego. And he actually was one of the first, I think, the first radiologist to become board certified in pain medicine. And the way he did it is he did the fellowship, applied for a fellowship at UC San Diego, who's already faculty, completed the fellowship, and then was able to be boarded under the American Board of Psychiatry and Neurology. And at that time, they sponsored him to sit for the exam, and then he was able to take and sit for the exam and get certified. A few years later, another gentleman, Rick Obrey, did the same thing, but then he was able to be sponsored by the American Board of Physical Medicine and Rehab. Around the time that I was applying, there was a lot of political change going on in the field of pain medicine, and the anesthesiology board was simultaneously closing options and opening them at the same time. So they said, well, we're no longer going to let just anybody be able to be co-sponsored by other boards. You have to have your primary board sponsor the examination. So I appealed to the American Board of Radiology, and I had multiple organizations involved in that, the ASSR, the Spine Radiology Society, Skeletal Radiology Society, Interventional Radiology Society, all kind of rally around this, where they wanted to lobby for pain medicine to become an official subspecialty of radiology, since many of the procedures were actually even invented by radiologists. So long story short, I wrote an 80-page application for the ABR to then submit to the ABMS, the American Board of Medical Specialties, and then we were successful in getting that through, so that pain medicine became an official subspecialty for radiology. Now, as a result, now the other boards that applied was the American Board of Emergency Medicine and also the American Board of Family Medicine. So pain medicine is now an official subspecialty of those fields as well.
Wow. Okay. All right. So let's dig more into pain medicine. What types of patients are you treating?
Oh, wow. So it's all over the board. So it can be on the developmental, spectrum, as from, say, my youngest patient last year was, I think, 8. And my oldest patient was well into her 90s. And where I was in Florida, I would say the mode was probably, 80-year-old females. And then I had, of course, a spectrum along the way.
What are you treating them for? What are you seeing an 8-year-old for?
So the 8-year-old was for chronic hip pain, I believe. And it ended up being ultimately a biomechanical issue. She had pes planus, or flat feet. She needed orthotics. I gave her a few exercises. I prescribed no medications. I said, come back after a month of doing these exercises, see how you do. We actually incorporated some martial arts into her exercises because she was enjoying martial arts at the time, and I'm actually a black belt myself. And then after a month, she was pain-free. So she had been a bit of a diagnostic mystery for her pediatricians and orthopedists, and then they sent her over to me because she was a, quote, chronic pain issue at that point, and then we were able to figure out what's wrong.
So moral of the story is being a ninja fixes everything.
Exactly.
All right. And so you said the mode is are these 80-year-old females. What types of things are you typically treating them for?
Back pain is by far the most common diagnosis that I see. So neck pain and back pain. When it comes to back pain, it's very multifactorial. So it's like, the lower back, for example, is a very complex structure. Your sacroiliac joints, your facet joints, your discs, your nerves, muscles. I would say muscle pain is actually the most commonly missed diagnosis in lower back pain in the chronic pain clinic setting, because I think most pain doctors feel like it should be picked up earlier and then sort of ignore it, or just don't see past that as the major pain generator, and then go treating deeper things when it really is majority muscle. So,
okay. Describe a typical day in the pain clinic.
Let's see. It depends. So it depends if I'm on clinic or if I'm on procedure day. If it's a mixed day, so I would say between 8 and noon, I would see about 15 to 20 patients, whether they're new or follow-up. And then let's see, go in, let's say, for a 10-minute follow-up on someone who I did facet injections previously. Let's say they're doing well, we'll continue them with physical therapy. I would follow up along, reading notes from the physical therapists. Other patient types that I can see, let's say, chronic regional pain syndrome. We might do regional blocks for that, or something ultrasound guided, like a stellate ganglion block. Let's see. Other, peripheral type things. Let's say someone comes with chronic ankle pain, we can inject joints under ultrasound guidance. And all those can be done on a typical clinic day, very similar to a sports medicine clinic day. If medical students or residents have seen or shadowed sports medicine. And then on a procedure day, that's usually when I'll have epidurals, facet injections, nerve blocks, things like that are going to be image guided under fluoroscopy. Those are scheduled, and then at that point I stay in lead all day. My nurses and my techs will bring patients in from the waiting room, get them prepped and ready to go. They've already been consented. And then it's pretty much procedure after procedure. And the nice thing is it's one of those things where patients have surgery. A lot of times they're in pain afterwards, or they feel, uncomfortable or some sort of discomfort. It's one of the few things where patients come in, they get on the table, right afterwards they're pain free. They cry and give you a hug right away. That's how happy they are. So that's kind of the rewarding part of the field.
That's pretty cool. What percentage of patients do you think that you see do you actually perform a procedure on?
That's a good question, actually. I would probably say about 60 to 70%. It's definitely not everybody. A lot of patients will respond to physical therapy. As I said, I'm also a physical therapist, so with that experience, I have a general idea of who responds well to that, who may need a little kind of push or a little injection to get them temporary relief in order to be able to tolerate more physical therapy. And then there are patients, of course, who just flat out refuse to go to physical therapy, and those are probably the most challenging because they have the shortest term relief with those injections that I perform, or the procedures that I perform.
Yeah.
In general, I'm a multifactorial kind of holistic kind of person. Injections are only, they're temporary for the vast majority of patients. And really what helps long term is physical therapy and rehabilitation. And that's actually, I think, reflected in the newest guidelines, where physical therapy and exercise modalities are going to be the first line of defense rather than prescribing opioids or doing injections, things like that. Yeah, that's a complete switch from, at least when I was in medical school. I actually remember one of my deans who taught a primary care class saying, "There's no evidence for physical therapy. We absolutely should not be prescribing it for patients with back pain." And that's that. And now it's kind of a complete 180, which I think is much more appropriate.
Yeah, and from my experience, I'm an exercise physiology background and was a trainer for a long time, so.
Oh, cool.
I'm very familiar with the PT side of the house. That's actually where I started. My healthcare desires was to be a physical therapist, but it changed. Awesome. The role of, would you agree that the role of the injection is more to reduce the inflammation so that they can do PT for that long-term results?
It's interesting. There's a lot of theories as to how injections work, and reducing inflammation is one of them. And here's I think where being a radiologist is also an advantage. Almost all these patients have an MRI for me to review, whether they've had it prior or they end up getting it because I order it. And depending on what I see on the MRI, I really consider myself a subspecialty trained spine radiologist, having the neuro and the MSK background. There are patients who will have stone cold, normal, non-contrast MRIs. You give them a little contrast, and their synovium of the facet joints light up, and that's an inflammatory process. So those patients are going to respond really well to steroids from a decreasing inflammation point of view. However, most of the time they don't. It's a matter of like a chronic osteoarthrosis sort of phenomenon where there's really not much inflammation going on, but there is remodeling and there's irritation of bone on bone arthritis. And those patients respond to a combination of local anesthetics and steroid, because the steroid actually will allow the local anesthetic to last longer. Now, how long? The truth is, no one really knows. And the spiel I give my patients is, some patients report relief for 2 days, some for 2 weeks, some for 2 months, some for 2 years, and some not at all. And one of the challenges we have in pain medicine is really figuring out who is going to respond the best and the most to the procedures that we do for the best bang for their buck, and our buck. Yeah. And I've actually figured out a few things based on what I can see on MRI. For example, that synovial enhancement. I've had any patient who I've done injections on who've had that sort of finding, they do phenomenal long term. That has never been published before. But those are the sort of correlations that I'm finding out, being both a radiologist and a pain physician. So eventually I think we'll get to those kind of correlations and studies. But for now, my current job keeps me pretty busy.
Okay. Do you have to take a lot of call as a pain med doc?
Actually, the interesting thing about at least outpatient pain, you don't take any call. The practice I was in, it was a Monday to Friday, 8 to 5 sort of scenario. And there was no call, no weekends. If patients had issues, they were instructed to call the emergency room or their primary care doctor, and then follow up during daytime hours with our office if they had a real issue that they felt was, urgent or emergent. And that's the way most chronic pain doctors practice in the country.
Okay. Do you feel like you have enough work-life balance as a pain med doc?
Oh, yeah. I mean, as a pain doctor, I'm currently practicing as a radiologist, which is much better as far as lifestyle goes. But I think as a pain doctor, it sort of depends on your practice setting. So if you're just opening a private practice, you're probably not going to have a great work-life balance because you're developing your practice. You're putting your heart and soul and gut and time into developing it, so you have no vacation. But on a typical, steady state, you'll have your, 3 to 4 weeks of vacation a year. You work Monday to Friday, 8 to 5, 8 to 4, and it's pretty regular hours, no call, no weekends, that sort of thing.
Okay. So we already talked about the path to pain medicine, how there's a bunch of different foundations for it. Once you're done with the foundational residency that you're doing, is everybody applying to the same fellowships, or are there different pain fellowships for each of the different residency specialties?
That's actually it's a great question, because the process is sort of unifying more and more every year. It is the same umbrella and category of fellowships. They are largely housed in anesthesiology academic programs throughout the country. I believe only 6 or 7 are currently in physical medicine, and only 1 is in a neurology department, 1 or 2 at the most at this point. And everyone's applying for those fellowships. And depending on the department, there is some bias, whether it's exactly calculated or not, for taking certain number of anesthesiology residents or PM&R residents for their program. So, for example, now if you apply for pain medicine, if you're anesthesiology, it's pretty much you're across the board. You can apply to any program and expect to be fine. If you're PM&R, there are a certain number of spots allotted for some fellowships, and it's reflected in this way when you apply for the actual fellowship, on ERAS, that you can only apply for a certain number of spots within each program. And there's the way that the ERAS program actually sorts them out.
Okay.
So there's anesthesiology and non-anesthesiology spots, basically.
Okay. Interesting. Is matching competitive?
Matching is actually very competitive. I don't have the most recent statistics, but the last statistics I had looked at were, I think, from like 2015, and it was something like 65% of those who applied ended up matching. So that means 35% did not, which is a large a large percentage of people.
Mm. Yeah, and it's for a fellowship, so it's not like these people are not matching out of medical school, so it makes it a little bit better, but still.
Exactly.
Yeah.
Exactly.
What should a resident be doing to make themselves a competitive applicant?
So if you're anesthesiology, it's built into your program. You're going to be doing a couple months of pain medicine no matter what. So go on your rotation, work hard, show some interest, do a couple more elective rotations, get hands-on, do as much hands-on as you can, really ask, and sometimes you even have to beg for the fellows to give up their procedures or work directly with the attending to do some procedures. But do it, and it's worth it. And if you feel like you enjoy it, by all means apply. Research always helps, getting active involved, and doing a presentation for a society meeting, which is really actually not that challenging. Some people go, "Oh, I hate research. I don't want to do this." But if you really write like a little review or an educational exhibit for a conference, it shows some initiative. It really tells the attendings that you're willing to put a little extra work in, and it's truly not that much work to put in. If you're a PM&R resident, seek out pain doctors who are fellowship trained through this process. Get to know them, understand, get their tips, get their connections. A lot of times it's not necessarily what you know, but who you know. So really network as much as you can. And the same advice as far as the anesthesiology resident type issues that I gave just now. Just put that a little extra effort in to do a little bit of research and get to know the people in your department and work with them.
Okay. Once you are subspecialized or specialized as a pain doc, what opportunities are there, if any, to further subspecialize?
So that's interesting. There's a lot of, so as part of pain medicine training, you do some hospice palliative care training, more on the palliative care than hospice, but a little bit of that. So you can work in that setting. You can do subspecialty just in cancer pain. And cancer pain is a lot of, it is a lot of opioid management, but it's not opioid management where you're going to worry these patients are going to get chronically addicted and have such negative long-term side effects from opioids because they don't live that long. It's really for palliative care. And then the procedures involved tend to be a little more complicated for cancer pain patients. So they're the more autonomic ganglion type blocks. So your stellate ganglions, your celiac blocks, things like that. And also, if opioids don't have a complete effect for relieving their pain, many of these patients go on to get intrathecal opioid pain pumps. And that's another type of procedure that is very effective in cancer pain, was thought to be effective in non-cancer pain, but then was found out really that it just does not work for non-cancer pain and probably should not be done for non-cancer pain anymore.
Are the boards for pain med anything to worry about?
That's an interesting question. Anything to worry about? I think just like any other boards, you're going to study, you're going to work hard. I think because so few people talk about pain medicine boards in general, there's this kind of fear about them. I'll tell you, for those who are in pain fellowships right now, it's almost identical to the process of taking the in-training exam, and some of the questions are even identical. So if you did well on the in-training exam, you're going to do well on the boards. A lot of people think they have to pay for these large courses, and the truth is you don't. There are books that are available online some are even available for free that you can download and do those questions, and you'll be completely fine. There are question banks online that will give you practice. They're fairly expensive, and to be honest, probably only marginally useful. Some are even not even written well, but because there are so few resources for the pain medicine boards, they still tend to sell very well. But overall, I think easily you can do it with just a free book.
Because somebody listening to this might not be interested in pain medicine, but is going into primary care, if you were to speak to him or her, what do you wish they would know as a primary care provider to help
Right.
you do your job better, to make their job easier?
I think the number one thing I'd want to communicate to, primary care, but not only primary care, all fields who are referring to pain medicine, is that pain medicine does not equal opioids. Pain medicine equals a comprehensive management for pain. That's both behavioral, procedural, medical, and rehab. And a lot of patients who come see me originally, will say, well, I'm out of my Percocet, and my primary care doctor said, it's not, you're the one who's going to prescribe it now because it's illegal for him to prescribe it. And those are, that unfortunately became many of my patients, and was just simply not true. It's never illegal for a primary care doctor to prescribe opioids, for one thing. But the bottom line is opioid care is not good pain care. It requires procedures and rehab and other types of medications that are much better for pain. So if you're going to refer to pain medicine, I think that patients need to have a clear expectation, at least initially, of what to think and they're going to receive on the first day. And it's certainly not going to be, of a controlled substance. So,
okay. What other specialties do you work the closest with?
Neurology gives us a lot of referrals, neurosurgery. A lot of times, nerve blocks before surgical procedures are performed to decide what level of a surgery is going to be performed, if they're going to do a single level fusion. I get a lot of referrals from orthopedics, patients who have chronic knee pain here and there, and maybe they tried injections, they don't want to do surgery, but orthopedics really focused on doing surgery. They'll send to us for the non-operative management. Lots of primary care referrals. Where else can I tell you? I think that covers the vast majority of it.
Okay. Are there, as a pain med doc, are there any special opportunities outside of clinical medicine?
It's a question. I think, as in any field, you can do medical legal consulting. I have not done any personally myself. I've had a couple offers, but nothing that really lined up time-wise that I was going to do. What else can you do? You can present for various pharmaceutical companies, and if you do that, there's, of course, lots of ethical issues involved, and you want to make sure that you're not just pushing a drug, but you actually make sure it works for your patients or something along those lines.
Yeah.
But nothing I can think of specifically. Otherwise, a lot of pain doctors will open up their own surgical centers for financial reasons and for essentially money making, right? It's a business, so a lot of real estate opportunities and pain for that sort of thing.
Okay. What do you wish you knew before going into pain management, pain medicine?
That's a question. I think that so I went in from radiology, and radiology is very cognitively challenging throughout the day. Your mind is constantly going. It's never stop. I think in pain, it's less cognitively challenging because you have practice patterns that you get into, and step-by-step management. And you kind of know what the next step is going to be with most patients. And so the cognitive aspect isn't there as much as the emotional aspect. It's very emotionally challenging throughout the day. Minus the successes, I'd say 20% of patients do really well. Some of them do neutral, and a chunk of them just don't get better, period. And it's not to the fault of, any, particular physician. That's kind of why they're there to see me in the first place, because it's chronic pain issue. But I think that, what I would have loved to know is how emotionally taxing throughout the day, the practice is. You have a lot of patients who are crying, who feel hopeless, that external locus of control, that they feel like they're down in the dumps. And a large part of my population when I was practicing in Florida was Medicaid. So on top of the challenges that they have of having chronic pain, they also have financial issues. And on top of even the financial issues, as far as the practice or the treatment opportunities I can even offer them, there were no physical therapy practices that took Medicaid. A lot of the procedures I offered that I thought would actually be best for patients were not covered. And the organization I worked for didn't believe in free care. So I wasn't allowed to provide those procedures. So in the end, they were stuck taking medications that they did not want to take because that was the only options they had. And some of them were stuck taking opioid medications because that was the only class of medications that their insurance company or Medicaid would cover. So this is part of a process in how our country, and a very large part of our country, has become addicted to prescription opioid medications. And that sort of leads into how I'm back to practicing radiology, because I didn't really believe in this process that's kind of self-feeding and defeating at the same time. How we're making the problem, unfortunately, worse nationally rather than better. So,
okay. So you answered. I would assume that would be your answer if I asked you, what do you like the least? Sounds like
yes, that would probably hit the least.
Okay. So what do you like the most about being a pain doc?
I mean, by far, when patients get better, they get better. And that kind of ties into why I chose radiology. A large part of chronic pain is a diagnostic dilemma for these patients. You have radiologists who are reviewing images who have never put their hands on the patient. You have many pain doctors who may not have the understanding of certain subtleties and nuances in reviewing imaging. But when you bring those two skill sets together, a lot of them will get better with the right diagnosis and the right directed, targeted treatment, whether it be injection or physical therapy or whatever else. So it's very rewarding when you see someone who's been struggling for well over a year, if not multiple years, who finally just do significantly better.
If you had to do it all over again, would you still choose pain med?
Absolutely. I mean, despite the political issues that are going on in the country, I think that it's a fantastic field. It's extremely rewarding. It really challenges you on every level, right? You have to know your imaging, your physical exam, your entire physical exam, not just your neuromusculoskeletal. You have to be an expert in your classes of medications that cross over even into neurology, but also into psychiatry. You used to say, I learned in medical school, people always try to stay away from the psychiatric medications as much as they can, because only psychiatrists understand it. And really, pain medicine embraces those medications. And then also, it's just a fantastic field. It's very emotionally rewarding when patients do well. So,
what do you see on the horizon, if anything, any major changes, whether it's from technology or maybe just a fundamental shift on how it's practiced, maybe based on what you've been talking about, that you see coming to pain med?
So on the horizon, I think there's going to be more technology that's going to be dedicated to things like spinal cord stimulation. It's a device that you implant. The battery gets implanted subcutaneously, and then you have leads that are implanted in the epidural space that create electronic bursts or electronic signals that will actually block pain signals. And it used to be patients would feel a buzzing sensation as sort of covering up the pain sensation they would feel. But now actually there's great technology out where patients don't even feel that buzzing sensation and just the pain is blocked. So I think as more of these types of technologies come out, I think they're going to come forward in the algorithm of treating patients earlier with higher end procedural intervention rather than going to medications, doing steroids on a frequent basis, doing local anesthetics on a frequent basis. And the other thing I think it has a lot of potential is therapies with stem cells. I think as more research comes out, I think there's going to be some certain niche indications for stem cells and certain types of stem cells to be injected into various joints and tendons and nerves that will cause and that will stimulate healing.
Any last words of wisdom for the resident medical student or pre-med student listening to this that's interested in pain med?
Sure. Do what you love. I mean, if you really want to do it, despite the political climate, go for it. At the end of the day, you're going to be extremely well rewarded for the work that you do. Patients are going to love you. You get tons of Christmas cards, tons of hugs. And at least when I thought of becoming a doctor, that's kind of how I pictured it. I actually thought of a lot of patients who were going to say thank you. Whereas a lot of times, unfortunately in the primary care setting or other fields, you don't get that thank you. That's not the only reason to do it, obviously, but it's a very rewarding field. It takes a lot from you in terms of, mentally, emotionally, physically. But at the end of the day, it's well worth it.
All right, there you have it. Pain medicine from a community doc and a radiologist by training. Now, as Dr. Weiss talked about, you can get into pain medicine from various different specialties. And I want to talk about pain medicine and hear from those different specialists as well, to hear maybe a different aspect of pain medicine as from being a neurologist, as he talked about, or a PM&R doc, or one of the other specialties, and to see if that gives them a different perspective, or they find something else that they like about the specialty different than Dr. Weiss talked about. So, if you have a specialty you want me to cover here on the podcast, shoot me an email, ryan@medicalschoolhq.net. I've been getting a lot of great suggestions, and I keep adding those to the list. And I'd love for you, if you know anybody that would make a great guest here on the podcast, let me know that as well. I hope you have a great week. Come join us back next week here at Specialty Stories.